Good morning, everyone. Welcome. Thank you very much for coming out on this Saturday morning to what we hope will be quite a lively and entertaining symposium. A very warm welcome in particular to a group of doctors who've come a long way this morning, all the way from China, who are over here on a UK education exchange, so you're all very welcome. Indeed, as we say in Ireland, Céad Míle Fáilte, which means 100,000 welcomes. Lovely to have you with us. My name is Jane Lynch. I'm a lead cancer nurse at HCA Healthcare UK, based predominantly in the Harley Street Clinic area. I've been in cancer nursing many years, and there is no doubt in my mind that we are currently in one of the most exciting eras of oncology. With the advent of immunotherapy, we are seeing unprecedented survival and progression-free survival in patients that we never thought we would only 4 or 5 years ago. A very good example of this would be some of your metastatic end-stage, stage 4 diseases such as lung cancer, renal cancer. However, with this treatment, there comes difficulties in our knowledge, in our expertise, and we're still learning. That is why today you will see a large group of expert consultants, expertise on the panels. In fact, we've never had such a large group come to these mornings. And that's an indication of the dedication to our patients, but also to our commitment to care. This is a new era for us. We want to share our expertise with you, but also learn from you. So without further ado, I would like to introduce you to Dr. Toby Arkenau. Toby has very kindly stepped up to chair the meeting this morning as Dr. Chowdhury was unable to make it due to personal reasons. Dr. Arkenau is our medical director for Sarah Cannon Research UK and clinical oncologist, medical oncologist, in particular in GI. Toby, can I hand the podium over to you? Thank you very much.
Thank you.
Thank you.
Good morning. Cao Chang Hao, Tebi Huan Jing. Did I say this right? Says good morning and a very special welcome for our Chinese delegation. We're very pleased because what we are doing here for the second time, effectively, the introduction of cancer care, oncology care in the HCA group, really bringing together our different specialities, not only oncologists. Oncology has changed from purely treating patients with chemotherapy to a multimodality treatment, including cardiologists, gastroenterologists, immunologists, pulmonologists, and so on. So you will see this morning a variety of the talks we have focusing, particularly in the multidisciplinary team meeting, on these issues, particularly when patients are treated with immunotherapies. There will be talks about how to manage side effects of immunotherapies. And this is really important for you as GPs. Patients are often treated in our clinical practices, but often later, months later, after they have received their treatment, patients may develop side effects which often appear related to autoimmune diseases, features like rheumatoid arthritis, liver dysfunction, and so on. So being aware about the potential side effects which can occur with immunotherapies is really important. So one of the focus this morning will be the management of the toxicities. Then I will talk to you a bit about what's the future, what does the future bring. I've actually changed my talk a bit and called this talk Cancer in 2030. So it will actually bring you into our day-to-day practice as well. So the GP service being a fundamental part of cancer care, I think is really important. And that's why I'm saying we have 10, 12 years time to make this all happening. But I would be very interested in your feedback, but also your engagement as well. And then finally, I think the highlight of the day, one of my patients, Mohak, who is and has undergone immunotherapy, will share together his experience, how he has experienced as a pioneer in GI cancers, how to be treated on immunotherapies, and his kind of experience and management, being in the system of side effects and so on. So that really will be a highlight at the end of the day. I am also supposed to talk, I got the slides last night, about, and it's really important, again, to understand why we're so confident about integrating our care, bringing and commit ourselves with an HCA, commit to cancer care so much. Transforming outcomes is important. It's not anymore the survival curve of 1 year. It's about long-term survival. Cancer is chronic disease. We have built over the last 2 years under the leadership of our CEO, Claire Smith, and Professor Tony Goldstone, really brought a team of experts together, and it's an integrated service. World-class care, and the focus is here on care. Care means the integration of the treatment and support services we have, and then the patient-focused expertise, of course, often for patients as well, after they underwent standard of care treatments, the long-term survivorship, follow-up, well-being, and so on. This is now, over the last 2 years, since we brought these things together, these pillars of cancer care effectively showing the first fruits, and again, you will be witness this morning of this first event in the UK. And really important for you to understand why we feel it is so relevant, a quality structure, a governance structure. So we have built effectively within, and as you know, we have seven hospitals in central London, the Christie in Manchester. It is so important to see cancer in a departmental structure with the relevant peer-to-peer tumor boards to build a relevant governance structure. So the care you get right now at London Bridge or the Wellington in cancer is an integrated platform. And this really goes from early diagnosis to end-of-life care. And again, if we are not there yet, give us a feedback. This is evolving, emerging, and we want to be the best in this to effectively help and support our patients. What are we offering? The network aspect is important. We're not a tertiary center. We're a network of sites and well interconnected. We're consultant-led multidisciplinary team meetings, most important for our outcomes. Our patients have comprehensive and are part of a comprehensive journey with access to clinical trials and research. The overarching tumor boards, I think, is really important, where, again, a peer-to-peer specialist, surgeon, and gastroenterologist, and medical oncologist filing guidelines to support our patients. And then finally, again, so important are the quality outcomes, long-term outcomes, to show actually that our care is better than the average care. I want to highlight here in this slide the way our network works. Again, we are a network, we're not a tertiary site. We have pretty much access throughout London to the HCA brand, whether it is GP services to then diagnostics, tertiary, and our hospitals. I think one important thing, for example, in the central London area, we just focused our oncology service, particularly the inpatient service, into the Princess Grace Hospital, and to give an even better dedicated research and clinical access for our inpatient as well. Because I'm the executive director for Sarah Cannon, have to talk and will talk, and very keen to talk about our clinical research experience. Again, this is absolutely unique in the UK, but I think for hospital providers like HCA as well, really important, integrating research into day-to-day care is standard of care practice. We opened the Sarah Cannon Research Institute 8 years ago as the first research unit outside the NHS, but with access to NHS patients and private patients. Effectively, our patients come from all ways of life, walks of life, referred to us for clinical research. Clinical research, our focus at Sarah Cannon, with now 25 years history in the US as well, is access to early clinical trials where we often test hypotheses, test new ways of treating patients. We're very lucky and fortunate to have offered our patients for the last 6 or 7 years immunotherapies through clinical trials. And through these initiatives, I think our patients will have even much better care. In the UK, we have now participated in more than 150 clinical trials, and effectively are part of a network of research units which are based in the US as well, the largest research network globally. So why choose HEA? HEA Healthcare UK, of course, it's an integrated service. The innovative cancer treatments we are offering, whether radiotherapy, hematological transplants, as you know, very strong at UCLH. It is about patient care and quality, the clinical trials access really important, and the holistic care as well, the support service, the dietetic service, physiotherapy, really important. And importantly, you may have heard at other events, our wellness program and Living Well program, again, core pillar of this success. I want to mention again, last year was, or the last 2 years, as part of restructuring this service, we had great successes. The Quality Care Commission ranked our services, our hospitals and cancer services included in this as outstanding. There's no other healthcare provider at this scale, at this network scale, having such a high outstanding rating. Of course, again, we are interconnected globally, as you can see through our Chinese guest here today. I've also a doctor from China, from our Ningbo visit, visiting us, Dr. Li, who is a drug developer who wants to learn. So what we are offering is interconnectivity, so please join us in our network approach. So these are my few words to highlight where we are, and you will hear during the morning what we are delivering and offering, and please feel free to interact with us. Thank you very much. Of course. I'm not following the rules here. So, of course, the second key part here is the MDT. I'm really excited to introduce you Dr. Thomas Newson-Davis, who is chairing this session, the MDT session. So, really important here for you to see this is a live MDT. This is not staged. We haven't seen the cases. They were apparently submitted last night at 11 o'clock. This is live, multidisciplinary, as it would be in our weekly MDT meetings. Again, feel free if you have any questions to ask. We try to, the shortness of time, 2 cases, and you will see all aspects. Good. And Tom is doing the presentation first. Great. Thank you.
Thanks very much. My name is Tom Newson-Davis. I'm a medical oncologist here in Harley Street, but also in West London, in Chelsea and Westminster Hospital. I'm going to talk a little bit before we do our MDT about immunotherapy. And I am aware there's quite a range of expertise in the room. There are people who will be familiar with oncology treatments and may be familiar with immunotherapy. There will be oncologists who are not familiar with this. There will be general physicians, there will be general practitioners, there will be oncology nurses, there will be research nurses. So I'm going to try to cover all those bases. So if I cover things that you know already, then I'm sorry, but you can feel very proud that you know it already, and you can sit back and have a coffee. If not, then I hope the contents of this will help you. So the first question is, who first gave immunotherapy for cancer? We think about immunotherapy as a new treatment. We think about it as something that only began in the past 5 years, but actually the first person to give immunotherapy for cancer was around 3000 BC, a guy called Imhotep. Imhotep was a remarkable man. He was a king, he was a philosopher, he was an astronomer, he was also a doctor. If you remember the excellent film, The Mummy from the year 2000, this is Imhotep as well. He was a baddie in the film. Imhotep writes, and we've got the documentation of this, treating people with neck swellings. And he would deliberately cut open neck swellings, and he would put on a pack, including mud and crocodile dung. And the aim seemed to have been to deliberately cause an infection. So probably what these guys had probably was a lymphoma, maybe TB, but who knows. And by causing an infection and using that cytokine storm, that immune reaction, apparently it made things shrink down. I'm not sure how successful it was, but he was ahead of the game. Modern immunotherapy for cancer starts probably a little bit over 100 years ago, 150 years ago. This guy, Rudolf Virchow, of Virchow's node fame, and he was a pathologist. Didn't treat patients, but he was a pathologist. And what he noticed when he cut up the cancers, as you can see on the right, he saw there was cancer there, but also what he saw was lymphocytes, immune cells infiltrating into that tumour. And he hypothesized there must be some kind of immune activity. If the cancer's there and immune cells are coming in, surely the immune system is doing something. But proving that transpired to be a remarkably difficult thing to do. An enormous amount of time and effort and money was spent trying to prove the immune system has no role in cancer. And to my mind, the first time that was really shown in a living organism as opposed to in a test tube was in 2001 using mice. And they used mice which had been bred to have no immune system. They're called RAG knockout mice, no functional adaptive immune response. And they did two things. They proved, number one, that on the right-hand side, if you paint a carcinogenic chemical called methylcobalamin or MCA onto a mouse, onto a normal mouse, well, a certain number of those mice will get a cancer. On the bottom line there saying WT. If, however, you use a mouse which has not got a functional immune system and you paint the same chemical on, many, many more of the mice, more than half of them in fact, develop that cancer. And what that tells us is that every day in the background, our immune systems are helping protect us from cancers and perhaps protect us from carcinogen-induced cancers. So without an immune system, we're more likely to get it. Now that's all well and good, but with a bit of luck, not many of us in the room here smoke, and therefore carcinogen cancer, I hope, is less of a problem. What about spontaneously occurring cancers? Well, this is what the graph on the left here shows. And what you can see, if you take normal mice and you just let them live a normal, healthy mouse life for 3-4 years, vast majority of them live happily and remain well, and a small number develop benign tumours of various bits of the body. If, however, you take a mouse without an immune system, without a functional immune system, and you leave them alone, every single one of them will develop a tumour, either benign or malignant. So again, what that says to us is every day working away, not only protecting us from bacteria and viruses, our immune system is also protecting us from cancer. That's a wonderful thing. Now, I did my PhD in immunology, and I used to do an immunotherapy course, and I was very excited, similar kind of size audience, and this was my conclusion in 2010, not that long ago. Very excited because on the right there was a publication in the New England Journal of Medicine of a type of immunotherapy called Sipuleucel T, which is used in prostate cancer. And as you can see, it was a bit better than giving placebo. And I was very excited about that. And you can see that's a survival curve with survival on the vertical axis and time on the horizontal axis. Not the most impressive curve, but I was extremely excited by this. And we also had some things about vaccination strategies. And I was getting excited because there was a 5% response rate. That was then, and I think that's fair to say it was a fairly disappointing situation to be in. What I'm going to show you now is what's happened subsequently and the enormous changes that we've had in that time since 2010. So immunology is difficult, and many people in the room have not thought about immunology since their training. So I'm going to give you Tom's idiot guide to immunology. Now, I wrote this slide again when I did my PhD, and I haven't seen a better one, frankly, so I've kept it. So I'm going to explain to you immunology in my idiot's guide, and if I can understand it, frankly, anyone can understand it. So the basics of tumor immunology is very similar to the immunology we have for infectious diseases, okay? Number one, I'm going to move away from the microphone now. Number one, we have our tumor cell. And there's a number of different axes to the immune system. One is called the innate immune response, and one is called the adaptive immune response. And the innate immune response will just see something and will attack it directly by recognizing patterns on that. And there are some cells, macrophages, neutrophils, polymorphineutrophils, and natural killer cells, which will directly recognize certain patterns on tumor cells and will get very excited and attack them. The relevance of that is not quite so sure, but the more exciting part from our point of view is the adaptive immune response. And what happens in the adaptive immune response is this. Tumours have tumour antigens. These are proteins of the tumour cell which are abnormal because, as you know, tumour cells have lots of mutations in them. So these are mutated proteins which we hope are specific for the cancer cell, which the immune system can get excited about and can recognise, because we all know that the immune system looks for things which aren't ourselves, they're not self. They're tumour antigens. And those tumour antigens get taken up by dendritic cells. And I put an eye in front of it because these are immature dendritic cells. And your immature dendritic cells patrol your peripheral tissue. They're wandering around looking for trouble. And they're taking up proteins, antigens. And they're doing that, looking to see if there's trouble. And they take them up and then they migrate. And they migrate to your lymph node. And the thing in grey on the right is your lymph node. So they will then take up that protein, the antigen, they will then move to the lymph node and they'll become mature, which is why it says M, mature dendritic cells. And they present that antigen on their surface. And they present that antigen to all the cells you can see sitting in the lymph nodes. The T cells, the B cells, the cytotoxic T cells, natural killer cells, all the whole bunch of them. And if that is something which looks foreign and looks like something we should be worried, the immune system should be worried about, those cells get very excited, they proliferate like anything, they leach out of the lymph node and they go off into the peripheral tissue and they will attack that. And if that is a tumour cell, they will attack the tumour cell. And that's kind of how it works. And what we're trying to do in tumour immunology is make that an efficient system. The trouble is, the tumour cell is very clever, and the tumour cell is very clever at escaping the immune response. I was once told by a colleague of mine that the stupidest cancer cell is cleverer than the cleverest oncologist, and I think that's absolutely right. So they can escape this system. And all the immunotherapies that we're going to talk about are aimed at trying to get that system to be as effective as possible, because it transpires the immune system is the most effective way of treating cancer. So my last scary immunology slide is this one. We need to think about how the immune system and the tumour cell interact. And you may remember that what happens, you've got your T cell up here, and you've got your tumour cell or antigen presenting cell at the bottom here. And for the T cell to get excited and attack that cell, it's got to recognise it. And it does it by recognising the tumour antigen on the T cell receptor of the T cell recognise the tumour antigen presented on the tumour cell. That's called signal 1. For the immune system to get a response, you need signal 2, a second thing to really get it excited. And those are called co-stimulatory molecules. And there's one here on the right, interaction between these two guys. So if you have signal 1 and signal 2, much excitement, T cell gets activated, steams in there, and destroys a cell. But as you all know, everything in the human body, for every activating system, you have a negative system to calm it down. And that's really important, because otherwise every time we see a bacteria or a virus, we will liquefy ourselves into a bag of pus, and that is no good. So we have negative regulatory pathways. And there's one here on the left called PD1, PDL1, standing for programmed death ligand. And on the right, we have a molecule called CTLA4. And these are called checkpoints. They slow the system down. They're the brake on the system. Very important part. From our point of view, what is immunotherapy? Immunotherapy are drugs which block those two pathways. So they are blocking the brakes on the system. They are cutting the brake cables on the car, if you want to think about it that way, allowing all the exciting stuff to happen without the brakes on the system. And there are essentially 4 principal agents. They're not the only ones. There are others in development. But from our intents and purposes, there are perhaps 4 principal agents. 3 here, which block this pathway, and 1 on the right, ipilimumab, which blocks CTLA4. And they're monoclonal antibodies, and they sit and they work by blocking that pathway. Now, if you look into a cancer, you may see one of 3 different things. You may see in that cancer, the blue cells, then there's lots of immune cells that have got into that cancer. They've infiltrated into it. But for some reason, it hasn't managed to get rid of the cancer. So that's an inflamed cancer because the immune cells are in there and they're ready to go, but they just can't get excited. And that's because, to go back one, this pathway has switched off the T cell. T cell's there, but it's been switched off by this pathway. Alternatively, what we might find is actually there aren't any immune cells in the cancer itself. They're either being pushed to the outside in the middle picture, they're stuck in the lymphatics, and they can't get in there. It's called immune excluded. Or there's absolutely no immune cells at all. It's just cancer cells, and that's sometimes called an immune desert. And cancers vary in different people, different types of cancer, different bits of cancer. And that's going to tell us we have to take different approaches to treating patients. With these guys, when the immune system's there and it's ready to go, if we can take the brakes off the system, maybe by blocking this one, for example, then you're going to get a great response. They're going to get really excited and attack the cancer. On the right-hand too, we're going to have to do a little bit more. We're going to have to do other approaches to get the cells in there as well. And that's a situation where we may need more than one immune treatment. We may need combination therapies. And we're learning as we go that these guys are going to be more difficult to treat. What cancers does it work on? Well, on the bottom here, we have a line of a whole different types of cancers going along. And the picture on the top, the higher those collection of dots as they rise up, the more mutations there are in the cancer, more somatic mutations in the cancer. And some cancers have a high number. On the right-hand side, you can see there's bladder, lung, melanoma. And on the left, we have things like AML, thyroid cancer, Ewing sarcoma. There is a connection, as you might imagine, between bladder, melanoma, and lung cancer. They're all caused by carcinogens, smoking and UV light, respectively. So by and large, the cancers with the greatest number of mutations are the ones caused by carcinogens, and the ones with the lowest number of mutations tend to not be caused by those things. Immunotherapy is probably going to be most effective on cancers with more mutations. In other words, the cancers on the right-hand side. And the reason for that is you've got more tumor antigens, you've got more targets for the immune system to see. There's more mutations, there's more abnormal protein, and the immune system can get more excited. Whereas in these guys here, with a small number of mutations, there's fewer abnormal things for the immune system to see, and therefore it's going to struggle a bit more. So I believe that immunotherapy can be used in a very wide range of cancers. I not only believe that, I know it, but probably it's going to be more effective on the guys towards the right-hand side than the guys to the left-hand side of this picture. So, I'm a lung cancer oncologist. I know very little about melanoma, so forgive me if people know more about it than I do. What's the history of immunotherapy? What do we know about its use? Well, the very first time it got reported was in August 2017. It's a slight disappointment for me because I mentioned my PhD, and I finished my PhD in July 2010. And I was a great believer in it. I think it's fair to say it was a bit disappointing. Large amounts of money spent, not much achieved, as per that previous slide of the not very exciting vaccination strategies. And then a month after I finished my PhD, went back to clinical work, this paper came out in New England Journal of Medicine. And it's about melanoma patients. And these are patients with advanced melanoma, which you will know is an awful disease. And they'd had a first-line treatment. These were second-line treatments. Large number of patients. And what this group were looking at is they were looking at giving patients a vaccination with something called GP120 or GP120 with ipilimumab, which you might remember from the diagram I showed you was the drug on the right-hand side of the synapse, just to go back one, this guy here, blocking that pathway. And what this showed, if you were in the group that got the ipilimumab, you did better on your survival curve than if you just got the vaccination. You might say, well, yeah, Tom, that's all right, but it's not that exciting. I mean, the curve is still pretty abysmal, and unfortunately, 2 months into treatment, still 80% of people have died. And that's true, but just have a read of what's in the red box there. So for those of you at the back, the thing to see at the bottom is it says, no therapy has been shown in a phase 3 randomized controlled trial to improve overall survival in patients with metastatic melanoma. So it's the first study to improve survival in melanoma. And it wasn't a chemo, it was an immunotherapy. So that was the first indication that, do you know what, this might work? And this was very, very exciting. Things have moved on a lot since then. Different drugs have come in, and you remember from the synapse picture I showed you the left-hand side with the PD-1, PD-L1 agents. Nivolumab is a PD-1 blocking agent. And that's used as a first-line treatment of melanoma because I'm afraid chemotherapy in melanoma is extremely ineffective. What we see is that compared to chemotherapy, in the first-line treatment of metastatic melanoma, immunotherapy is vastly superior. I'm not a melanoma doctor, as you know, but even I can tell that this is a better treatment. Not only that, but if you compare the side effects on the right-hand side there, you will see that the side effects of chemotherapy are much better than the side effects of, side effects of immunotherapy are much better than the side effects of chemotherapy. So it works better and it's easier to have. It's an absolute no-brainer. So immunotherapy has absolutely transformed the treatment of melanoma. Not only that, but if you begin to use those two immunotherapy drugs together, remember the synapse picture where you have the PD-1 blocking drugs on the left and the CTLA blocking drugs on the right. If you use those drugs together, you can get more effect. These are first-line treatment, 900 patients, and what you can see if you combine therapies, which you can see on the right-hand side is a dotted line, you can see that there is an improvement in survival. So melanoma patients are often younger, they're stronger, you combine the drugs, you really can get impressive results. Melanoma is a terrible disease, but in terms of the numbers of people affected by cancer, lung cancer is right up there at the top in terms of the incidence of lung cancer and the mortality of lung cancer, the biggest killer in terms of mortality in the globe. So what about treatment of lung cancer? Second-line chemotherapy for lung cancer is a very disappointing process. It's not very effective, it doesn't work very long, and it's highly toxic. So when immunotherapy came along, we compared immunotherapy to chemotherapy. And this is a drug called pembrolizumab, a drug that blocks PD-1, PD-L1, and which was compared to chemotherapy in patients, and there's two different groups of patients, those with high levels of the target on the cancer cell and those with lower levels of the target on the cancer cell on the right-hand side. And you can see how people get on with chemotherapy in the black line, and you can see the pembrolizumab, there's two different doses, red and blue, don't worry about that, it's all the kind of same thing. You can see the patients survive much better in those who receive immunotherapy compared to chemotherapy. So immunotherapy became and has become an absolutely standard treatment in the second-line therapy for lung cancer. Here's a picture of a case which we'll go into a little bit later, of a lady with a mass in her lung, which has responded very nicely to immunotherapy, just to prove that they're not lying. Not only that, it doesn't just treat the lung, it can treat other bits and pieces as well. This is her brain metastasis. She had no treatment for this, no systemic treatment for this, and it shrunk down with immunotherapy very nicely. What works in second line is often then moved into the first line. And this was data that came out in lung cancer originally about 2 years ago, most recently an update a year ago. These are patients with high levels of the marker of the immunotherapy drug, PD-L1. Instead of giving chemo, in the grey line, you have immunotherapy as well. And what you can see as a first-line treatment of lung cancer, people do much better. Now, when I was a trainee, and I said to my boss as a registrar, I quite want to treat lung cancer. I find it really interesting. He said to me, why do you want to do that? You only make people live 6 weeks longer. And he was right, because at that stage, we just had chemo. Just look at those survival curves. You need to be a little bit careful about this, because this is quite an immature survival curve, and I'm not suggesting that people live forever, not how it's been. But the most recent data would suggest that in these patients having immunotherapy, their average survival is around 30 months. This represents about a third of our patients, usually the more heavy smoking patients. It's very nice for an oncologist to be able to say to someone, I'm going to give you this treatment, and I think it's going to work for somewhere between 2.5 and 3 years. Whereas previously I would say, I'm going to give you chemotherapy, and it's going to work for 2 or 3 months. So highly effective first-line treatment in lung cancer. This is now widely used, and we need to make sure that our patients have access to these drugs and are treated appropriately for them. Hi. Just one drug. Just pembrolizumab. Yeah, yeah. I've got other stuff on that as well in a second, but you're correct. Renal cell cancer, so the reach of immunotherapy goes beyond lung cancer and melanoma. Renal cell cancer, we can see that immunotherapy appears to be superior to a drug called everolimus as well. That's the limit of my knowledge about renal cell cancer, but it works there as well. Then we begin to think, well, hang on, if chemo works a bit and immunotherapy works as well, what happens if you put them together? And so, reflecting my bias in lung cancer, apologies, but it is the most exciting subject in the world. What happens if you combine chemo and immunotherapy? The answer is it gets even better. So on the right-hand side, these are people, treatment-naive lung cancer, given chemotherapy in red or chemotherapy and immunotherapy in blue, and you can see their survival is even higher. And you're having up to 80% of patients, or 75% of patients, I think it was, alive at a year. So So this is a really impressive situation where you can be confident your patients are going to do better. We still have to be candid that these are not curative treatments. They don't work on everyone by any means, but they are much better. And what's interesting is that the side effects of chemoimmunotherapy are really not significantly worse than the side effects of chemo. So this is not a treatment you're going to reserve for your super fit 40-year-old patients. This is something you can give to anyone you would be considering chemotherapy for. This is a licensed treatment, but making sure that patients are treated in an MDT where the team have familiarity with these cutting-edge treatments is absolutely essential. Can you cure people with immunotherapy? It's a really good question. We don't really know the answer. There are patients with melanoma who are in long-term remission with immunotherapy, and probably, yes, they have been cured. It's the exception, not the rule, but long-term control is possible. In lung cancer, is that going to be possible? Well, maybe. After radical treatment with chemoradiotherapy, which we do for people with locally advanced treatment, we know it improves overall survival. And before surgery, there's some really interesting data. So before surgery, whilst the surgeon is preparing the plan for surgery, if you can get 1 or 2 immunotherapy treatments in beforehand, it looks like you can shrink the cancer down. You can have pathological, complete responses within the lymph nodes in the chest. And that might become a really interesting part of what we do. So working closely as an MDT with oncologists and with surgeons is such an important part. This is all very exciting, and we might all think, well, this is fantastic, Tom. Everyone's going to get immunotherapy. There are huge challenges with it. It's not a straightforward process. The treatment does come with side effects. By and large, it's better tolerated than chemotherapy. People don't tend to feel sick. Their hair doesn't tend to fall out. They don't lose appetite or have taste change, the kind of things patients find very difficult with chemo. But there are toxicities, and we're going to go into a couple of these in a few minutes. You can have quite complicated toxicities involving bits that oncologists suddenly feel extremely unsure about. Cardiac side effects, GI side effects, respiratory side effects, endocrine side effects. It can be quite difficult to assess response. With immunotherapy, sometimes cancers don't just shrink down like they do with chemo. Sometimes they stay the same. Sometimes they get a bit bigger before they get a bit smaller, something called pseudoprogression. So working with our radiology colleagues to try to understand it and getting a group around you who's got a lot of experience in this is really important. There is a suggestion in some patients, maybe the immunotherapy will provoke the cancer to grow more quickly. Something called hyperprogression. It's a very contentious issue at the moment. But even the basics, we don't actually know how long to give these drugs for. We have no clinical trial data in the advanced setting. All we know is that we should not stop after 1 year. We don't know we should go for 2 years, 3 years, 4 years, 5 years. No one knows. And therefore, we don't really know when to stop. And it creates lots of trouble because if someone is doing very well on treatment, at some stage you've got to think about stopping. At some stage, when do you stop? How do you stop? We have to think about the cost of drugs at an individual level, institution level, but also at a national level. And we have to think about access to make sure we're having access to them. And then there are other issues such as chemotherapy unit capacity. It's a really important thing. So my chemotherapy clinics 4, 5, 8 years ago, you'd see people 4 or 5 times on chemo, and then they would be followed up. And I'm afraid to say they weren't followed up for very long because the disease would come back, and often they wouldn't be well enough for treatment. Now I've got people on treatment for 2 years. I'm seeing they're coming to clinic every 3 weeks for 2 years. I've run out of all conversation. I've run out of things to say to them. And they're bored of seeing me and I'm bored of seeing them. I'm not really. It's wonderful to see them, but it creates problems. And these patients have chronic treatments. And suddenly the chemotherapy units are full of well people having maintenance treatments. And it's a real challenge for us. So immunotherapy is very exciting. Immunotherapy is a great thing, but it comes with those challenges. What's next? I think what we will see is trials in every tumour type. In fact, we've already seen trials in every tumour type. I think we will see more of these treatments move from people in a second-line setting to first-line treatment. We're going to see combination of new immunotherapy drugs. We're going to have more chemoimmunotherapy, and we'll see more agents coming through. And having people like Toby involved, good access and good relationships with clinical trials units is so important because these drugs appeared in the clinical trials units, and they were developed through patients going for clinical trials. And so we should continue that excellent work with our colleagues. This is my favourite picture. I don't expect you to read it. What it is it's every dot is a clinical trial. This is about a year and a half out of date. And going from the outside to the inside are phase 1, phase 2, and phase 3 studies. And each slice on the pie is a different tumour type and this is one immunotherapy drug. And that's to give you the number of trials, the number of trials, the number of different areas that these drugs are involved in. It is truly a change in the way in which treat cancers. So, what I'm going to do is I'll ask my learned colleagues to come up and sit, I think, from the right-hand side. And we've got a couple of cases we're going to go through, and I'm going to compare it. And they're just going to, two cases reflecting the complexities of people on immunotherapy. So if I could ask everyone to come up, and I shall talk through. So we have Toby Arkin, who's met already, who's our clinical trials lead. We have Chris Foster, who's a consultant histopathologist. Chris, the back coming up. David Lawrence, who is a thoracic surgeon. Jane, who you've already heard from. John Connie-Bear, who is a clinical oncologist. Neil Navani, who's a respiratory physician. Alex Lyon, who's a cardiologist. And Gavin Johnson, who's a gastroenterologist. And you have to look at the screens either side, I think, to see the case. Locking the brakes on the system. They are cutting the brake cables on the car, if you want to think about it that way, allowing all the exciting stuff to happen without the brakes on the system. And there are essentially 4 principal agents. They're not the only ones. There are others in development. But from our intents and purposes, there are perhaps 4 principal agents, 3 here, which block this pathway, and 1 on the right, ipilimumab, which blocks CTLA-4. And they're monoclonal antibodies, and they sit and they work by blocking that pathway. Now, if you look into a cancer, you may see one of 3 different things. You may see in that cancer, the blue cells, that there's lots of immune cells that have got into that cancer. They've infiltrated into it. But for some reason, it hasn't managed to get rid of the cancer. So that's an inflamed cancer because the immune cells are in there, and they're ready to go, but they just can't get excited. And that's because, to go back one, this pathway has switched off the T cell. T cell's there, but it's been switched off by this pathway. Alternatively, what we might find is actually there aren't any immune cells in the cancer itself. They're either being pushed to the outside in the middle picture, they're stuck in the lymphatics, and they can't get in there. It's called immune excluded. Or there's absolutely no immune cells at all. It's just cancer cells, and that's sometimes called an immune desert. And cancers vary in different people, different types of cancer, different bits of cancer. And that's going to tell us we have to take different approaches to treating patients. With these guys, when the immune system's there and it's ready to go, if we can take the brakes off the system, maybe by blocking this one, for example, then you're going to get a great response. They're going to get really excited and attack the cancer. On the right-hand too, we're going to have to do a little bit more. We're going to have to do other approaches to get the cells in there as well. And that's a situation where we may need more than one immune treatment. We may need combination therapies. And we're learning as we go that these guys are going to be more difficult to treat. What cancers does it work on? Well, on the bottom here, we have a line of a whole different types of cancers going along. And the picture on the top, the higher those collection of dots as they rise up, the more mutations there are in the cancer, more somatic mutations in the cancer. And some cancers have a high number. On the right-hand side, you can see there's bladder, lung, melanoma. And on the left, we have things like AML, thyroid cancer, Ewing sarcoma. There is a connection, as you might imagine, between bladder, melanoma, and lung cancer. They're all caused by carcinogens, smoking and UV light, respectively. So by and large, the cancers with the greatest number of mutations are the ones caused by carcinogens, and the ones with the lowest number of mutations tend to not be caused by those things. Immunotherapy is probably going to be most effective on cancers with more mutations. In other words, the cancers on the right-hand side. And the reason for that is you've got more tumor antigens. You've got more targets for the immune system to see. There's more mutations, there's more abnormal protein, and the immune system can get more excited. Whereas in these guys here, with a small number of mutations, there's fewer abnormal things for the immune system to see, and therefore it's going to struggle a bit more. So I believe that immunotherapy can be used in a very wide range of cancers. I not only believe that, I know it, but probably it's going to be more effective on the guys towards the right-hand side than the guys to the left-hand side of this picture. So, I'm a lung cancer oncologist. I know very little about melanoma, so forgive me if people know more about it than I do. What's the history of immunotherapy? What do we know about its use? Well, the very first time it got reported was in August 2017. It's a slight disappointment for me because I mentioned my PhD, and I finished my PhD in July 2010. And I was a great believer in it. I think it's fair to say it was a bit disappointing Large amounts of money spent, not much achieved, as per that previous slide of the not very exciting vaccination strategies. And then a month after I finished my PhD, went back to clinical work, this paper came out in New England Journal of Medicine. And it's about melanoma patients. And these are patients with advanced melanoma, which you will know is an awful disease. And they'd had a first-line treatment. These were second-line treatments. Large number of patients. And what this group were looking at is they were looking at giving patients a vaccination with something called GP120 or GP120 with ipilimumab, which you might remember from the diagram I showed you was the drug on the right-hand side of the synapse, just to go back one, this guy here, blocking that pathway. And what this showed, if you were in the group that got the ipilimumab, you did better on your survival curve than if you just got the vaccination. You might say, well, yeah, Tom, that's all right, but it's not that exciting. I mean, it's not, the curve is still pretty abysmal. And unfortunately, 2 months into treatment, still 80% of people have died. And that's true, but just have a read of what's in the red box there. So for those of you at the back, the thing to see at the bottom is it says, no therapy has been shown in a phase 3 randomized controlled trial to improve overall survival in patients with metastatic melanoma. So it's the first study to improve survival in melanoma. And it wasn't a chemo, it was an immunotherapy. So that was the first indication that, do you know what, this might work? And this was very, very exciting. Things have moved on a lot since then. Different drugs have come in, and you remember from the synapse picture I showed you the left-hand side with the PD-1, PD-L1 agents. Nivolumab is a PD-1 blocking agent, and that's used as a first-line treatment of melanoma because I'm afraid chemotherapy in melanoma is extremely ineffective. What we see is that compared to chemotherapy, in the first-line treatment of metastatic melanoma, immunotherapy is vastly superior. I'm not a melanoma doctor, as you know, but even I can tell that this is a better treatment. Not only that, but if you compare the side effects on the right-hand side there, you will see that the side effects of chemotherapy are much better than the side effects of, side effects of immunotherapy are much better than the side effects of chemotherapy. So it works better, and it's easier to have. It's an absolute no-brainer. So immunotherapy has absolutely transformed the treatment of melanoma. Not only that, but if you begin to use those two immunotherapy drugs together, remember the synapse picture where you have the PD-1 blocking drugs on the left and the CTLA blocking drugs on the right. If you use those drugs together, you can get more effect. These are first-line treatment, 900 patients, and what you can see if you combine therapies, which you can see on the right-hand side is a dotted line, you can see that there is an improvement in survival. So melanoma patients are often younger, they're stronger, you combine the drugs, you really can get impressive results. Melanoma is a terrible disease, but in terms of the numbers of people affected by cancer, lung cancer is right up there at the top in terms of the incidence of lung cancer and the mortality of lung cancer, the biggest killer in terms of mortality in the globe. So what about treatment of lung cancer? Second-line chemotherapy for lung cancer is a very disappointing process. It's not very effective, it doesn't work very long, and it's highly toxic. So when immunotherapy came along, we compared immunotherapy to chemotherapy. And this is a drug called pembrolizumab, a drug that blocks PD-1, PD-L1, and which was compared to chemotherapy in patients, and there's two different groups of patients, those with high levels of the target on the cancer cell and those with lower levels of the target on the cancer cell on the right-hand side. And you can see how people get on with chemotherapy in the black line. And you can see the pembrolizumab, there's two different doses, red and blue, don't worry about that, it's all the kind of same thing. You can see the patients survive much better in those who receive immunotherapy compared to chemotherapy. So immunotherapy became and has become an absolutely standard treatment in the second-line therapy for lung cancer. Here's a picture of a case which we'll go into a little bit later, of a lady with a mass in her lung, which has responded very nicely to immunotherapy, just to prove that they're not lying. Not only that, it doesn't just treat the lung, it can treat other bits and pieces as well. This is her brain metastasis. She had no treatment for this, no systemic treatment for this, and it shrunk down with immunotherapy very nicely. What works in second line is often then moved into the first line. And this was data that came out in lung cancer originally about 2 years ago, most recently an update a year ago. These are patients with high levels of the marker of the immunotherapy drug, PD-L1. Instead of giving chemo, in the grey line, you have immunotherapy as well. And what you can see as a first-line treatment of lung cancer, people do much better. Now, when I was a trainee, and I said to my boss as a registrar, I quite want to treat lung cancer. I find it really interesting. He said to me, why do you want to do that? You only make people live 6 weeks longer. And he was right, because at that stage, we just had chemo. Just look at those survival curves. You need to be a little bit careful about this, because this is quite an immature survival curve, and I'm not suggesting that people live forever, not how it's been. But the most recent data would suggest that in these patients having immunotherapy, their average survival is around 30 months. This represents about a third of our patients, usually the more heavy smoking patients. It's very nice for an oncologist to be able to say to someone, I'm going to give you this treatment, and I think it's going to work for somewhere between 2.5 and 3 years. Whereas previously I would say, I'm going to give you chemotherapy, and it's going to work for 2 or 3 months. So highly effective first-line treatment in lung cancer. This is now widely used, and we need to make sure that our patients have access to these drugs and are treated appropriately for them. Hi. Just one drug. Just pembrolizumab. Yeah. I've got other stuff on that as well in a second, but you're correct. Renal cell cancer, so the reach of immunotherapy goes beyond lung cancer and melanoma. Renal cell cancer, we can see that immunotherapy appears to be superior to a drug called everolimus as well. That's the limit of my knowledge about renal cell cancer, but it works there as well. Then we begin to think, well, hang on, if chemo works a bit and immunotherapy works as well, what happens if you put them together? And so, reflecting my bias in lung cancer, apologies, but it is the most exciting subject in the world. What happens if you combine chemo and immunotherapy? The answer is it gets even better. So on the right-hand side, these are people, treatment-naive lung cancer, given chemotherapy in red or chemotherapy and immunotherapy in blue, and you can see their survival is even higher. And you're having up to 80% of patients, or 75% of patients, I think it was, alive at a year. So this is a really impressive situation where you can be confident your patients are going to do better. We still have to be candid that these are not curative treatments. They don't work on everyone by any means, but they are much better. And what's interesting is that the side effects of chemoimmunotherapy are really not significantly worse than the side effects of chemo. So this is not a treatment you're going to reserve for your super fit 40-year-old patients. This is something you can give to anyone you would be considering chemotherapy for. This is a licensed treatment, but making sure that patients are treated in an MDT where the team have familiarity with these cutting-edge treatments is absolutely essential. Can you cure people with immunotherapy? It's a really good question. We don't really know the answer. There are patients with melanoma who are in long-term remission with immunotherapy, and probably, yes, they have been cured. It's the exception, not the rule, but long-term control is possible. In lung cancer, is that going to be possible? Well, maybe. After radical treatment with chemoradiotherapy, which we do for people with locally advanced treatment, we know it improves overall survival. And before surgery, there's some really interesting data. So before surgery, whilst the surgeon is preparing the plan for surgery, if you can get 1 or 2 immunotherapy treatments in beforehand, it looks like you can shrink the cancer down. You can have pathological, complete responses within the lymph nodes in the chest. And that might become a really interesting part of what we do. So working closely as an MDT with oncologists and with surgeons is such an important part. This is all very exciting, and we might all think, well, this is fantastic, Tom. Everyone's going to get immunotherapy. There are huge challenges with it. It's not a straightforward process. The treatment does come with side effects. By and large, it's better tolerated than chemotherapy. People don't tend to feel sick. Their hair doesn't tend to fall out. They don't lose appetite or have taste change, the kind of things patients find very difficult with chemo. But there are toxicities, and we're going to go into a couple of these in a few minutes. You can have quite complicated toxicities involving bits that oncologists suddenly feel extremely unsure about. Cardiac side effects, GI side effects, respiratory side effects, endocrine side effects. It can be quite difficult to assess response. With immunotherapy, sometimes cancers don't just shrink down like they do with chemo. Sometimes they stay the same. Sometimes they get a bit bigger before they get a bit smaller, something called pseudoprogression. So working with our radiology colleagues to try to understand it and getting a group around you who's got a lot of experience in this is really important. There is a suggestion in some patients, maybe the immunotherapy will provoke the cancer to grow more quickly. Something called hyperprogression. It's a very contentious issue at the moment. But even the basics, we don't actually know how long to give these drugs for. We have no clinical trial data in the advanced setting. All we know is that we should not stop after 1 year. We don't know we should go for 2 years, 3 years, 4 years, 5 years. No one knows. And therefore, we don't really know when to stop. And it creates lots of trouble because if someone is doing very well on treatment, at some stage you've got to think about stopping. At some stage, when do you stop? How do you stop? We have to think about the cost of drugs at a individual level, institution level, but also at a national level. And we have to think about access to make sure we're having access to them. And then there are other issues such as chemotherapy unit capacity. It's a really important thing. So my chemotherapy clinics 4, 5, 8 years ago, you'd see people 4 or 5 times on chemo, and then they would be followed up. And I'm afraid to say they weren't followed up for very long because the disease would come back, and often they wouldn't be well enough for treatment. Now I've got people on treatment for 2 years. I'm seeing they're coming to clinic every 3 weeks for 2 years. I've run out of all conversation. I've run out of things to say to them. And they're bored of seeing me and I'm bored of seeing them. I'm not really. It's wonderful to see them, but it creates problems. And these patients have chronic treatments. And suddenly the chemotherapy units are full of well people having maintenance treatments. And it's a real challenge for us. So immunotherapy is very exciting. Immunotherapy is a great thing, but it comes with those challenges. What's next? I think what we will see is trials in every tumour type. In fact, we've already seen trials in every tumour type. I think we will see more of these treatments move from people in a second-line setting to first-line treatment. We're going to see combination of new immunotherapy drugs. We're going to have more chemo immunotherapy, and we'll see more agents coming through. And having people like Toby involved, good access and good relationships with clinical trials units is so important because these drugs appeared in the clinical trials units, and they were developed through patients going for clinical trials. And so we should continue that excellent work with our colleagues. This is my favourite picture. I don't expect you to read it. What it is it's every dot is a clinical trial. This is about a year and a half out of date. And going from the outside to the inside are phase 1, phase 2, and phase 3 studies. And each slice on the pie is a different tumour type. And this is one immunotherapy drug. And that's to give you the number of trials, the number of trials, the number of different areas that these drugs are involved in. It is truly a change in the way in which treat cancers. So, what I'm going to do is I'll ask my learned colleagues to come up and sit, I think, from the right-hand side. And we've got a couple of cases we're going to go through, and I'm going to compare it. And they're just going to, 2 cases reflecting the complexities of people on immunotherapy. So if I could ask everyone to come up, and I shall talk through. So we have Toby Arkin, who's met already, who's our clinical trials lead. We have Chris Foster, who's a consultant histopathologist. Chris, the back coming up. David Lawrence, who is a thoracic surgeon. Jane, who you've already heard from. John Conibert, who is a clinical oncologist. Neil Navani, who's a respiratory physician. Alex Lyon, who's a cardiologist. And Gavin Johnson, who's a gastroenterologist. And you have to look at the screens either side, I think, to see the case in providing optimal management for patients. The idea behind it is you bring everyone together and that improves the patient care. And tumour bores, or MDTs, are now widely used. In a lung cancer point of view, we would have all these people present. So respiratory physicians, radiologists, thoracic surgeons, medical and clinical oncologists, pathologists, palliative care, not present this morning, but a very, very important part, I think, of patient care. You should always try to have a representative of your clinical trials unit there so you can improve access to clinical trials. And you have your clinical nurse specialist as an integral part as well. You then might have members of your extended team, people you have good relationships with, you may not therefore be in every meeting, but you know you can get them involved as well. And for example, cardiology, gastroenterology are very important parts for us. So the first case I'm going to talk about is a 64-year-old lady called Carolyn, and she first presented with lung cancer in 2017. Watch out, guys, you want to get a screen in your head. She smoked. She smoked significantly. She had a 34-pack year history. And she had a performance status of 0. So she was very well. She was asymptomatic. But she did have medical comorbidities. Okay? She had ischemic heart disease, and she'd had a myocardial infarction in 2013, so 4 years before we met her. And in fact, it was as part of incidental routine follow-up for cardiac issues that she was found to have a mass on the lung. And what that mass was looked into, she had a PET scan and a CT, and she was found to have a left lower lobe primary tumour, a left upper lobe nodule, and a mediastinal lymph node. So you can see here the mass on the left-hand side. And I've got a couple of questions to ask my colleagues, just going back up the case. I'm actually going to start off with Alex from the cardiology point of view. This lady's had ischemic heart disease. She's had a myocardial infarction 4 years before we met her, but she appears also to have lung cancer. From a cardiology point of view, how important is it that her cardiac status is assessed, and what should we be doing to make sure that her cardiac issues are taken into consideration as part of her possible cancer treatment?
So, thank you, Tom. This is growing as a more and more common issue. I mean, a very obvious thing for lung cancer is the shared risk factors with heart disease. And this lady's obviously survived her MI, so we have a growing population of people surviving cardiac disease in their 40s, 50s, 60s to live to get cancer in later life, and they're importing this risk. So when I hear this story, what things I'm thinking about is what's her fitness for surgery for the general anaesthetic. I'm already thinking what's going to be any neoadjuvant treatments pre-surgery, chemotherapy. You've heard about immunotherapy that might then change her anaesthetic risk. And then in the follow-up after surgery, what will be adjuvant treatments and what are the potential cardiac risks. So with this, I think part of this is assessing her fitness for surgery. So that may involve stress testing to ensure there's no active ischemia, so she's fit for general anaesthesia. And there's another simple thing that can be done. There's data now that if you have a troponin rise during your cancer surgery, and this is actually data from lung cancer patients, you have a worse cardiac outcome afterwards. And as you've heard from Tom, now the patients are surviving, they're coming to his clinic so well that suddenly these other outcomes, including importantly cardiac disease, because that can lead to death, are having a relevant impact. So something simple like measuring a post-operative troponin might also guide who needs further cardiology review as well as their ongoing cancer treatment.
It's very helpful, thank you very much. So Neil, as a respiratory physician, this lady's come along, she's got some masses on her CT, we don't know what it is. We need to get tissue. Tissue is how we, of course, diagnose cancer. What options does she have in terms of diagnostic approaches?
So thanks, Tom. So sort of tissue acquisition in lung cancer has really become a really key issue over the last few years. So not only do we have to take tissue for a primary diagnosis, but it can also be used for staging. And then also we need all of the information to guide systemic treatments, all of our molecular diagnostics as well. So taking good quality tissue has really become an important part of lung cancer care. So looking at this, these images here, I think there's a couple of things we need to take into consideration. The PET scan suggests the mass in the left lower lobe is avid, and then I noted, Tom, that the PET scan report also suggests some mediastinal lymph nodes being avid as well. So I think we've got a couple of options. We can either do a percutaneous CT-guided biopsy of this mass. I think that would be a straightforward procedure to do. However, that wouldn't give us information about the mediastinal lymph node status. So another option would be to assess the mediastinal lymph nodes with endobronchial ultrasound. So this is a bronchoscopic technique that allows us to visualize mediastinal lymph nodes and acquire good quality tissue to provide a tissue diagnosis, but also a nodal stage, because I'm just wondering about, in this case, whether the nodal staging may actually influence some of our treatment decisions.
Thank you very much. So she went on to have a biopsy. In the end, she had an endobronchial ultrasound, and that was found to be an adenocarcinoma. And it's written down as TTF1 positive. We'll get onto that in a second. And she went on to have a left lower lobectomy. She went on to have surgery. David, if I could ask you from a surgical point of view, this lady was found to have mediastinal lymph node involvement. She had a primary tumour. Surgery is one option. Chemoradiotherapy is another option. From a surgical point of view, what are the considerations you take into account, and what do you say to your patients when you're thinking about surgery in this type of stage disease?
Thank you, Tom. So surgery is obviously, excuse me, a more invasive technique, but the yield is that you can get clearance of the primary tumor. We get a lot of tissue that then can be used for subsequent analysis. And the other important thing is that we can look to get into that mediastinum and get rid of all these lymph nodes. And what I see the surgical role of is that we get rid of all the disease that we can see. That does, of course, leave microscopic disease elsewhere that my colleagues deal with. But of course, the total tumor burden in the patient is significantly less. So chemoradiation is an alternative technique, and we would discuss relative benefits of that. It is a prolonged, it's a technique that takes longer and also has a range of side effects for the patient. But surgery is a good one-stop shop where you can get rid of a lot of disease so that my oncology colleagues have much less disease to clear afterwards.
John, some people would say that an alternative to surgery would be chemoradiotherapy. That's something that you and I do together. Tell me about what you see the options in terms of chemoradiotherapy for this lady, had she wanted to go down that route.
So I think it would be very important when you're performing your EBUS, Neil, to see which nodal stations are involved on biopsy evidence. When it comes to chemoradiotherapy, as David says, it's really a discussion that's held in the MDT to try and determine if the surgeon feels that the tumour is operable. In stage 3 lung cancer, often those patients are inoperable, and so chemoradiotherapy really becomes the only treatment option that offers a curative approach to their lung cancer. In this particular patient's case, she had N2 disease. She was found to be highly PD-L1 positive. And actually what's very exciting and what's actually recently happened is there's now data that's been presented to us in World Congress that shows that giving chemoradiotherapy and following that with a year's adjuvant immunotherapy actually improves survival in these stage 3 patients. And so that's a new paradigm in treatment for these stage 3 lung cancer patients. But going back to the very beginning, it's really the discussion at the point of MDT to determine whether the surgeon feels that their cancer is operable or inoperable. And that's where I think chemoradiotherapy plays an important role.
Thank you. So Jane, following discussion in the MDT, the patient has met the lovely John, she met the lovely David, she has a couple of options. From the CNS point of view and assisting the patient making a decision, tell me the things that you might be thinking about and the things that would be important for the patient.
So the clinical nurse specialist has in-depth knowledge of a particular tumour type. So in this case, it would be the lung cancer clinical nurse specialist, or CNS. With that will come advanced communication advocacy skills. So essentially, you're the patient advocate. So you should be able to sit with the patient, discuss all of the treatment options. And the questions I would be asking at the MDT would be, what does the patient want? So although we have fantastic evidence to support a year's worth of treatment, is that something that the patient would be able to do and want to do?
Thank you very much. So in the end, she elects to go for surgery, and as I mentioned, she has a left lower lobectomy. That's found to two things, one of which is found to have an adenocarcinoma. She's also found to have an atypical carcinoid. When the adenocarcinoma is tested, it's found to have high PD-L1 expression. You'll remember PD-L1 being the marker for immunotherapy on the tumour cell. Chris, I wonder if you could explain to us a bit surprised there that she's got an adenocarcinoma and an atypical carcinoid. Are these linked, or is this coincidental? And could you explain to me a little bit about PD-L1 testing and how it's done and the significance of that?
Right, thank you very much. Let's begin at the beginning. No patient has cancer until a pathologist says so, and that is a truism. And our role as histopathologists right at the very beginning is, as the patient's advocate, to ensure that before they are submitted to any sort of treatment, that we are absolutely sure of the diagnosis. And that's the role of the histopathologist. So not only do we ensure that they have a malignancy, but that the malignancy is of lung or other origin, in other words, that it's a metastasis. In doing this, the marker TTF1 has shown to be extremely valuable in segregating primary lung cancers from adenocarcinomas of other sites, with the exception of thyroid, which there's some overlap. So the first thing that we do is we ensure that we're dealing with malignancy, and second, that we're dealing with adenocarcinoma, carcinoma of the lung. Now, you probably know that within lung cancer, there are broadly 4 or possibly 5 major types. Adenocarcinoma is extremely common. And within adenocarcinomas, there are mimics of what happened in the normal tissue, which is an alteration in differentiation, so that within an adenocarcinoma, whether it's in the breast or the stomach or colon or elsewhere, within an adenocarcinoma, it is not an uncommon finding to find that other cell types begin to emerge. So neuroendocrine differentiation, which occurs naturally within the lung, also is occurring. Now you've also heard, so that's TTF1. You've also heard of PD-L1, and the PD-L1 does something slightly different in terms of histopathology. And that is that when we look at it, we look to see what is the level of expression, whether it's very small, less than 5%, in which case it's classified as being negative, or if it's greater than that, what is the extent of PD-L1 expression, because this may well be an indicator of the behavior of the tumor and its susceptibility to particular types of treatment. Now, as you've seen already from Tom, fantastic strides have been made in terms of introduction of immunotherapy. There is, however, a caveat, and this comes back to the laboratory, where we as pathologists are now performing additional diagnoses over and above that we did maybe just 5 years ago. And that is, if you look at any gene, the gene is made up of multiple exons. So for PD-L1, which is encoded on chromosome 9q, there are at least 4 different variants. So what we need to establish is, for a particular patient, not only is PD-L1 being expressed and that the gene itself is not mutated or is mutated, but which variant of the 4 is actually being expressed. Because it may well be that using the monoclonal antibodies that Tom has described, the epitope identified in the normal type, the mature type of PD-L1 is not expressed, but that there is a different molecule coming off the PD-L1 gene that is expressed. In other words, it would appear negative, but that this has a different activity in the individual patient. So the essence is that we as pathologists at the beginning should identify that it is a primary adenocarcinoma of the lung with particular biological and genetic characteristics for that individual patient, so that the appropriate biological management for that patient can be initiated.
Thank you very much. So in our MDT discussion, this lady, as you see, had undergone surgery. We discussed what might be possible, and the MDT felt that she should have adjuvant chemotherapy after the surgery with curative intent, and that's the side that I tend to do, that the chemotherapies, the immunotherapies, and the targeted therapies. So that was recommended, adjuvant platinum-based chemotherapy, and maybe think about some radiotherapy to the chest after that. So we aim for that. This was around a year ago, a little bit more now. But actually on the day of her first cycle of chemotherapy, she walked into my clinic room and she was limping a bit. And she was trying to cover it up a little bit, and her daughter said, well, a little bit worried because my mum has been a bit weak and something not right. So we did an urgent brain scan, and unfortunately she was found to have multiple brain metastases, which had occurred in the interval between preoperatively, when her scan was clear, to afterwards. So something had changed, the cancer had already metastasized, so suddenly we're in a situation of metastatic disease. This is a picture of her scan, and you can see on the left-hand side a large metastasis here with some associated edema, and on the right-hand side a metastasis in the cerebellum. John, from a radiotherapy point of view, she's actually still very well. She's a little bit weak on the left-hand side. You remember this lady very well. What radiotherapy options might she have before we consider our systemic treatments, which are likely to involve immunotherapy?
So really, thank you, Tom. There's 2 approaches to the brain with radiotherapy. You can either take the approach where you encompass the entire brain with radiotherapy, what we term whole brain radiotherapy, and that treats the disease within, but also the normal tissues around those sites of disease. It's normally conducted with a dose which we consider palliative, and it's normally conducted over the course of 5 to 10 days. The side effects of the treatment, the patients unfortunately lose all their hair, and it can have long-term effects, so it can cause problems with memory and cognition as time goes by. The alternative to that, which is a new approach really to radiotherapy to the brain, is something called stereotactic radiosurgery, where we use a very highly focused form of radiotherapy, where we treat the disease within the brain and try to avoid treating the normal parts of the brain around that disease. When it comes to deciding on the two modalities, there's some important things that we consider. The first is the size of the lesions within the brain. So patients with brain metastases greater than 3 centimeters, stereotactic radiosurgery isn't normally considered, because it's too large, and therefore we can cause significant toxicity to the normal brain around that lesion. In this particular patient's case, you can see the large lesion here on the right side, which was actually too big for stereotactic radiosurgery, whereas the other lesion further down here in the cerebellum would be an ideal candidate for treatment. Under these circumstances, again, it's important to come back to the concept of the MDT, and it's important to involve your neurosurgeons to see whether there's anything they can do for the patient, and therefore approach them in a joint way, where they may be able to do surgery, and then I can do stereotactic radiosurgery to whatever disease is left.
Thank you very much. So, Carolyn went on initially to have a palliative neurosurgical resection of the biggest metastasis because she was so symptomatic. And surgery can certainly be a very helpful palliative procedure for symptom control. And she went on to have stereotactic radiosurgery with John, as mentioned. And she actually remained very well. Her performance status, measure of how well she is 1. When we took out the tumour, we analysed that. It was a lung adenocarcinoma, as we'd expected. And again, it had high PD-L1 expression. So we discussed the various treatment options that this lady could have. And from a systemic treatment option, she now has advanced stage disease. She has brain metastases. And she has almost certainly micrometastatic disease elsewhere because the cancer's managed to escape from the original surgical site, lung site, to the brain. So what are her options? Well, her options could include just leaving her alone. She's had systemic treatment, she's had radiotherapy to the head. Maybe we should leave her alone. Or we should get on with some treatment because she is well and we want to control the cancer whilst it has at its smallest. And so the MDT opinion after that was to consider immunotherapy. And the reason why we've gone through everything so far and the surgery and so on is to show you that immunotherapy is an integral part of what we do, but it's not the only option. And it's something that should be used advisedly and carefully. Why didn't we recommend using immunotherapy straight after her surgery, before we knew about the brain mets? Well, the reason is at the moment it's not licensed in that indication. All the license for immunotherapy is an advanced stage disease. There are clinical trials going on, and Toby and colleagues are very important in that. But we didn't choose immunotherapy after surgery because at the moment there's no evidence behind that. And it's very important as we talk about immunotherapy to our patients to explain we can use it and we will use it if needed, but there's lots of situations we shouldn't. And in fact, this lady asked me at the time, well, can't I have immunotherapy, this amazing thing, after my surgery to get rid of it? And I said, well, outside of a clinical trial, no, we can't, because there's no evidence behind that. However, now that cancer's metastasized, she's got stage 4 disease, she's got high PD-L1 expression, as Chris mentioned. This is a lady who we should consider for immunotherapy. So she starts immunotherapy. She starts pembrolizumab, which is one of the anti-PD-L1 drugs, and PD-1 drugs. And she did really well. She performance status actually improved, came down to 0. She was asymptomatic. She was a little bit tired, and fatigue, I think, is one of the main side effects of this drug. And she was doing very well. But she then made contact with us about 4 or 5 months into treatment with abdominal pain and diarrhea. And we're very clear with our patients on treatment. Any problems, phone us up. And all chemotherapy units have very clear protocols about what to do. And abdominal symptoms in people on immunotherapy is a real concern to us. And one of our concerns particularly is sometimes patients don't contact us directly, but will go to their nearest A&E or will go to their GP who may not have the information about treatment. And the reason that makes us concerned is that there are some gastrointestinal side effects. Gavin, I wonder if you could talk to us about someone like this who comes to see us. You and I have had a couple of patients who are presented with GI symptoms on immunotherapy, the things that we should be thinking about and the kind of approaches that a gastroenterologist with an interest in immunotherapy would take.
I think the first thing to say is that a diarrheal illness in a patient on immunotherapy is a very different enteropathy, colitis, to those on standard chemotherapy. And I think still what is happening around the place is we're treating patients with oncology-induced diarrhea, oncology therapy diarrhea in all the same way. And if you've got a history of immunotherapy, it's an entirely different disease process. It is an active colitis, often upper GI involvement, often small bowel involvement. And it is pro-inflammatory. And if you look in the colon in a patient with immunotherapy induced diarrhea, you probably have something that looks exactly like ulcerative colitis or even Crohn's disease, which you would never see in quite the same way in a patient on chemotherapy. The chances of this patient developing a colitis is about 2% on Pembro, although the case series differ. The time frame fits. You want it to be at least 6 weeks for it to blame the immunotherapy to develop the diarrhea. And once it presents, the first question for the patient is to assess how severe things are. The European guidelines are very good. I'm sure we're going to hear about those this morning. So they're the ESMO guidelines on toxicities in these drugs. But I think they run the risk of undercalling the severity of a GI involvement, if anything, because they use the very blunt tool of stool frequency to talk about grades 1 to 4 diarrhea. 6 bowel movements would represent grade 2, which you might think is fairly mild. If I had a patient with ulcerative colitis, I'd be very worried about a patient having 6 bowel movements per day. So I think more useful is how often they're going to the toilet, how long are they there for, are they getting up 2 or 3 times through the night, is there urgency, is there blood, and all of those requires a fairly detailed history. And if all of those are on the more severe end of the spectrum, you've probably got a patient with a slightly worse colitis than you might infer based purely on the ESMO guidelines of stool frequency. Once you've determined that, you need to visit the laboratory to work out the severity of that colitis. So a CRP will help you. You need to ensure there is no GI infection, Clostridium difficile or just standard Campylobacter, etc. Plenty of that about, so don't be tricked by making the wrong diagnosis. It's not in the guidelines, but a fecal calprotectin, which looks for neutrophils in the stool, probably has a role in terms of severity, although that's not found its way into guidelines yet. I suspect it will. But if you're getting a patient up to 6 bowel movements per day, a little bit like Chris's remarks about histology, you can't say it's colitis until you've done a flexible sigmoidoscopy and taken some tissue off to the histopathologists. And what you should be putting on your request form from those colonic biopsies is CMV. Because if you've had a patient on lots of chemotherapy, relatively immune suppressed, an important differential that you will only potentially see on histology is CMV colitis. And if you treat that with steroids, etc., you're making a big mistake. So I think the early involvement of a gastroenterologist or an endoscopist is crucial in that regard. Once you're happy that this is immunotherapy colitis, then you step in fairly readily with immunocompromising medications. The first would be oral prednisolone, assess it 2 or 3 days to IV, either IV hydrocortisone or IV methylpred, and 2 or 3 days after that, we can get into infliximab and the biologicals that we use in inflammatory bowel disease. And I'm sure we'll see a bit more detail on that algorithm a bit later on.
Chris, you want to?
Yes, I do. And this is exemplified absolutely. One of the things that we would ask all of our clinicians to provide us with an adequate and relevant history when a piece of tissue is submitted. So, for example, a colonic biopsy with colitis query, which we receive frequently, is insufficient in this situation to be able to make a correct analysis and to be able to do the tests. Yesterday, I had a biopsy from a bladder of cystitis query, and this was on a 29-year-old lady who in fact had schistosomiasis because she'd been swimming in a lake in Malawi a few years ago. So there's a world of difference between having schistosomiasis and you treat it correctly and diagnose it, or similarly with the colitis that you're describing, we need to know the details in order to be able to deliver the diagnosis promptly and correctly.
Thank you, Chris. Jane, this lady, she's a lovely lady. She doesn't like to make a fuss. As you can see on the third bullet point down there, when she originally had her diarrhea, she was self-medicating with loperamide, with Imodium over the counter, even though we do say to people as soon as you have a symptom, let us know. Tell us a little bit about how the specialist nurse would work with the patient to make sure that symptoms are reported early, and how we try to encourage them, not always to sit at home being brave, but to let us know if there's trouble.
Yeah, it's very interesting. One of the challenges with immunotherapy has been getting patients out of that mode of chemotherapy. So with chemotherapy, they know they could manage things over the counter, they could have the loperamide, they wouldn't necessarily contact us for things that they felt they could manage with. They would stoically put up with it. So it's managing expectations for these patients. It's helping them understand. So this lady, we had to help her understand that reporting the symptom doesn't necessarily mean stopping the treatment. They're very fearful at this stage of stopping treatment. Immunotherapy has been a huge, should we say, nationwide, worldwide change in treatments. And patients know this, they see this. So they see this as their chance of survival, or certainly extended survival. And if it stops, the fear is that their cancer will take over. So it's helping them manage those expectations along with managing their side effects.
I think it's such an important part, that the fear of stopping immunotherapy for patients is vast, and there's a big underreporting of symptoms. We've got to be aware of it. And this is not in any way a criticism of a patient, because I think I would be the same, but the desire to be on these drugs, the pressure they feel to be on them, and then if the oncologist or anyone is saying, well, let's just hold them or stop them, they're terrified, so we'll often underreport symptoms. Gavin, what's the chance, this lady did indeed have an immune-related colitis, what's the chances of it getting better? I mean, hers did get better. And when it's got better, and she says to me, Tom, I really want to restart that immunotherapy because, this is so important to me. What's the chance of it coming back? Would it be reasonable for me to restart the immunotherapy, or am I being crazy doing that?
Good question. So if that's settled down with oral prednisolone, as the majority do, happily, it's a real difficult one, because you can pretty much guarantee that you will trigger a further colitis, and next time the colitis might be more aggressive. And if you start getting into grade 3 and 4 severity, there have been subtotal colectomies for immunotherapy-induced diarrhea. So it's a very challenging conversation for you to have with your patient. It's about informed consent, stepping in very early with further prednisolone. What has not been looked at is the role of prophylaxis, so to give oral budesonide, which stays within the gut and has a large first-pass metabolism within the liver, so it has fewer of the systemic toxicities of corticosteroids. That, to my knowledge, hasn't been looked at by way of preventing for the next round of immunotherapy. I'm sure that those sort of things we'll start to see. Yeah. But as soon as you get into 3 or 4, I would be very, very cautious.
Toby, through your clinical trials, you've had a lot of patients with a number of different tumour types, a number of different immunotherapy combinations. What's your approach to re-challenging with immunotherapy? If someone's had an immune-related side effect, do you feel confident re-challenging in some situations? Do you never do it? What's your approach in a trial setting?
A very good question. And the toxicity often not only affects the GI system, so we see very commonly pneumonitis, very low-grade pneumonitis, hepatitis, skin reactions, and as well increasingly endocrine dysfunction. So patients suddenly come up with high glucose levels, insulin levels, hyper or hypothyroidism. So effectively, the immune effect or the autoimmune effect can really affect all organs. And the rule of thumb, or in my practice at least, you need to recover to grade 1. And again, we can discuss the grading to restart and re-challenge immunotherapy. But I would be very, very careful, particularly with the organs lung, pneumonitis, hepatitis, where I would be much more careful to restart. Whereas someone has colitis and that can be managed through local steroids, I would be probably more inclined to restart if the response is there. So I think it's a very careful consideration. We've seen the same with hyperthyroidism. If you replace patients with thyroxine, for example, or hypothyroidism with thyroxine, patients tend to maintain and respond this. So it's not a clear answer. Yeah. Depends on the organ and intensity.
The other thing, in the context of diarrhea, is make sure they again have colitis. So my most recent patient in the last month or so, bladder cancer, pembrolizumab, a definite colitis through the summer, settled empirically without having an endoscopy, which you could argue perhaps wasn't the great thing, but she settled with oral prednisolone, relapsed, got her colonoscopy by a different gastroenterologist, active colitis, all fitted with Pembro, and then got herself up to 50, 60 milligrams of prednisolone, was sort of settling, then got infliximab, and then was stuck at about 6 bowel movements per day and on 50 of prednisolone, and it didn't quite fit because you're supposed to respond to infliximab. And you've just got to ask yourself what's going on here. And when I did a flexible sigmoidoscopy last week, she has 0 colitis. I gave her some bile salt sequestrants and she was transformed. So in fact, she had bile salt malabsorption, probably as a complication of the previous enteritis. And she went from 6 bowel movements a day, getting up through the night, to 0. And she'd been on steroids for long enough, she could barely get out of the chair, and is disinhibited enough to send me a picture of every one of her bowel movements and give me a big hug every time I see her. That's how disinhibited she was. So maybe when I next see her, when she's back down on her prednisolone, I won't get the hug and the photographs. Yeah. But just be sure you're dealing with what you think you are.
Yeah. And I think that's a really nice demonstration of why, if you're giving immunotherapy, you need to surround yourself with experts in the area so that you can phone them up, you can be in the MDT, and say, what's your experience of this? What should we do here? Because these are great drugs, but they're new drugs to us, and they're challenging to them. So in fact, we did re-challenge her with immunotherapy. Her bowel symptoms and her diarrhea did not return, and she continues on treatment. So I've got one other case which will be a little bit quicker. And just for a couple of you, just let you know, I have changed the case from the one we emailed a couple of days ago, so just to keep you on your feet. This one is a little bit different. I'm going to go through it a little bit more quickly. This is a young lady in her mid-40s, and she's one of the good people in the world. She is a carer in a nursing home in West London. And she came to see me quite a long time ago, as you can see. She was originally diagnosed at a different hospital to where I worked with metastatic lung adenocarcinoma. And she had multiple brain metastases. She had some molecular tests done suggesting that the only treatment at that time, it was 3 years ago now, was chemotherapy. So she had some whole brain radiotherapy, which John mentioned as a possible option for her brain metastases, and she had a couple of cycles of a standard chemotherapy. She actually then got worse after 2 treatments, and it was found that her brain scan was worse and her scanner for extracranial disease was worse. Treatment was stopped, and the patient was referred to the palliative care team for no further treatment and just best supportive care. And she came to see me as a second opinion to say, what else can be done? She was 44 at that stage. She's not an old lady. This is her scan of her head, and that's a scan of her lung. So when I saw her, she was actually clinically quite stable. I thought her performance status was about 1. She was pretty tired. She'd lost all her hair. She had some visual symptoms. But at that stage, immunotherapy was just coming in, and we just had begun to have access to it. And I arranged for original biopsy to be tested, and it found it was, the PD-L1 was 60%. And so she started an immunotherapy agent called nivolumab. Chris, in this, I've retested her original biopsy, not the one done about 6-7 months before I met her. Is that a reasonable thing to do, or should I have pulled out all the stops to try to re-biopsy her? Can I rely on original biopsy to guide my current treatment decisions?
Now, that is a very good question. Malignancies evolve, and we know that, and that's been well documented. And malignancies, metastases, give rise to second-generation metastases. So as a disease progresses naturally, you cannot assume that the genetic spectrum which occurred at the beginning is going to be the genetic spectrum that you see in metastasis down the line, particularly after you have given chemotherapy, at least, because that may or may not provide a selection, positive or negative, in terms of the clones and types, the genotype of the cells that are occurring. So the answer is you've got to treat the disease which you can see at the moment, not the disease that was present 5 years before.
And I think we discussed the rebiopsy. She was very unkeen on that, so we went with her original one. And she started immunotherapy, and actually she did really well. She came back a couple of months later. She was feeling better. Her visual symptoms have improved. She had no side effects to report. And in fact, her performance status was 1. Her hair was regrowing, having previously had whole brain radiotherapy. So this is her scan. You've seen a couple of those before. It was quite a long time ago. You might be thinking, why on earth are you showing me a scan this old? But there's a reason for it. So she does fine, and then in November of 2016, so she'd been on treatment for a few months, and I was slapping myself on the back of having done a magnificent job. But she came in with some new visual symptoms. No other neurological symptoms. She was otherwise completely fine. Her performance status was still 0. But her MRI scan, as you can see there, shows the progression of her right occipital metastasis. John, if you want to point to where that is, since you're nearer to me, thank you very much. The CT of her extracranial disease showed that everything continued to get better. There was still an ongoing stability, actually slight improvement. So she's just got this one area. Everything else outside of the brain is okay. John, what are our options in this lady who's previously had chemo? She's previously had whole brain radiotherapy. She's now got an isolated progression of that lesion.
So having had prior whole brain radiotherapy doesn't preclude her from further stereotactic radiosurgery. So I normally would want her scan review to ensure that there's just this solitary site of disease, which to my eye looks less than 3 centimetres in size. And so I would probably discuss with her the potential benefits and side effects of stereotactic radiosurgery.
Glad you said that, because that's what we did. And she went on to have stereotactic radiosurgery to that area, and there was an excellent clinical and radiological response. So she did really well for about another 6-7 months. But last summer, she developed a cough, and she developed some breathlessness. She was actually quite well with it, and she didn't really mention it for a while. But I noticed as she was coming up quite a lot, telling about these patients, you see them very regularly. I just noticed that, due to the genius of our clinic, it's a bit of a walk from the waiting room to the clinic, and I'd noticed as the weeks went on, she was a bit more short of breath coming in. She wasn't really pyrexial, her blood test showed no inflammatory markers, I didn't think she had an infection, but her oxygen saturations were just a little bit lower. This is her scan here. I actually have to confess it is actually not her scan, it's a scan of another patient, but I couldn't get her images off the packs. But the radiological picture was extremely similar. You will notice it's actually a man, not a woman. But anyway. Neil, there's some changes there. When I read the report, it said it was an organising pneumonia. I'm a simple oncologist. I don't understand these things. But I do know that immunotherapy can have effects on lungs. Tell us about immunotherapy and lung toxicity and how we might approach this.
Thanks, Tom. Yeah, no, happy to help. And I think it's a really important and growing role of the respiratory physician in the lung cancer MDT. Traditionally, we've been involved at the front end and the diagnostic end, but I think increasingly we're involved in caring for patients as they go through lines of treatment as well. So this is a really lovely scan that you've put up. This is a really nice example of an organising pneumonia. So an organising pneumonia is a patch of consolidation within the lung that is not caused by infection. So there's no bacteria there or pathogen there, but is typically caused by an immune infiltrate. And as you might imagine, in a patient on immunotherapy with their immune system activated, if that were to misfire slightly and the immune cells to go into the lung, this is the kind of appearance that we typically see. So typically we'll be able to see the air bronchograms just here through it, and the peripheral nature of it as well points to the fact that it's an organising pneumonia. So an organised pneumonia is just one type of lung toxicity that we see with immunotherapy. So we do see a wide variety of lung appearances. We can get patterns of fibrosis and quite commonly as well areas of ground glass change on the lungs. When we assess these patients, I think it's really important to exclude infection. So it's quite difficult sometimes in the history that you've described there, Tom, with a low-grade fever and cough and breathlessness to exclude infection as well. So where possible in these cases, we do like to carry out a bronchoscopy and lavage to obtain a cell count from this area. And typically in patients with organising pneumonia, you would expect a high proportion of lymphocytes in the lavage, versus compared to, for example, in an infection where you would typically see neutrophils. We also commonly see eosinophils in immuno-oncology induced pneumonitis as well. So the role of bronchoscopy as well, I think, is important in these patients. But as I'm sure you'll say in a minute, Tom, that an organising pneumonia does often respond extremely well to steroids. So we'd often start with a relatively high dose of prednisolone, but expect commonly the patient to respond well and rarely have to turn to second-line agents such as infliximab.
Thank you. Alex, the side effects of immunotherapy regarding lungs are better understood, better described, even simpletons like me understand that. The cardiac side effects is more specialised in something which we've begun to understand a little bit more about recently. Can you tell us the things we tend to see and what we should be watching out for? Is it safe to use an immunotherapy? Had this lady had an MI 5 years ago, would it still be safe to give immunotherapy?
So thank you, Tom, and I fully echo, we are learning on the way. These are new drugs, and the more we look, the more we start to find complications and then very challenging situations. The cardiovascular toxicity initially emerged as a concern after a paper in the New England Journal a couple of years ago with 2 cases of fatal myocarditis, and that sort of put up the alarm bells. And this situation is relatively rare compared to the diarrhea, the pneumonitis and other complications, but when it's a 50% mortality, this was very frightening. So the first thing to consider is if you have the breathless patient presenting, yes, think about the lungs, but if the lungs are normal, think about the heart and being vigilant to myocarditis. But the more we learning from this, what we're realizing is there are some other complications which are relevant. One is complete heart block without myocarditis. So if the patient is dizzy or fainting, think about that. We're now seeing some infarctions, myocardial infarction with chest pain. Some of it may be aggravation of atherosclerosis, because that is an inflammatory disease, and if you've already got plaques in your coronaries, they're ready to rupture. But maybe some is vasculitis and an immunological coronary vasculitis in the background of normal coronaries. Pericarditis we're seeing now as well. And finally, and this is what is interesting but complicated, is we're seeing some non-inflammatory heart failure. And I've got a growing group of patients with progressive left ventricular impairment getting symptomatic heart failure on particularly the PD-L1 antibodies, but there's no inflammation on cardiac imaging. Troponins are normal, but BNPs are rising. And it may be a little bit analogous to Herceptin heart failure, which is it's an antibody functional toxicity rather than inflammatory. So the other part of this, which you sort of correctly raise, logic tells me that if someone's previously had an MI or myocarditis from a virus, their immune system has seen cardiac antigens, they've had troponin rises, presumably they're at higher risk than the fit and healthy person. And I think because the melanoma patient population, which is obviously where this has all evolved from, have been younger, very little pre-existing cardiac disease, rates relatively low. Now we move into smokers, lung cancer, older patients with bladder malignancies, renal cancer. We're seeing more and more. And in fact, now I would say that every week I get at least 20 phone calls a week on potential cardiac complications of immunotherapy because it's becoming such a common issue. So my message is, think about the heart, be very suspicious of the dizzy or collapsing patient and also the breathless patient, and an ECG and a troponin are the starting point, and then we get into advanced cardiac imaging pretty quickly, because cardiac MRI is the best way to look for myocardial inflammation and sometimes cardiac PET-CT, and we also have a role for endomyocardial biopsy in the sort of grey cases where we're not sure. And then the final big elephant in the room is who can get re-challenged. And I think if it's autoimmune myocarditis with this high risk, I think that's a high risk. We've safely re-challenged patients with complete heart block after a pacemaker where they didn't have myocarditis, and also pericarditis. So the combination of steroids and colchicine, a standard treatment, medical treatment of other types of pericarditis, settle it and then re-challenge with careful monitoring.
Thank you very much. So with Neil's expert input, actually what we did with this lady is she did indeed have a pneumonitis. We held the nivolumab, we gave some steroids and prednisolone, as Neil mentions. We weaned that down over several weeks. And she was very well. Her symptoms went away, her performance status went back to 0, and we had the shall we re-challenge conversation, which Alex was mentioning and which Gavin mentioned earlier. And I said, well, there's a chance of the immunotherapy making your pneumonitis worse again, but there is a chance of it not coming back. And I said I thought there was about a 30% chance of the pneumonitis recurring, which is what the data would seem to show. She was very keen to re-challenge. She'd done incredibly well. She'd been told 2 years before that she was going to a hospice and that was it. And then she'd had this amazing response to immunotherapy. So she was desperate to continue. And that's one of the issues we get onto, which Jane had mentioned, the desire for the patient to continue. So we re-challenged with nivolumab. And I'm afraid her lung symptoms recurred. Within about 3-4 weeks of restarting it, we discontinued the nivolumab permanently. We gave her some steroids. Those symptoms went away. The scan returned to normal. And a year later, she's had no treatment for a year. There's been no radiological change. She's very well. Brain scan is unchanged. It's not completely normal. There's a couple of areas where she's had a stereotactic radiotherapy. She's still got a right lung lesion, but it's not growing. She's got no active disease. She's back at work, working in nursing home. She's been there for about a year and a half now. And she had no treatment, leading us to the tantalizing idea is, has this lady actually achieved some kind of long-term control of her disease? I've never used a cure word with her because I don't think she is, but we do know from clinical studies that there are groups of patients who do very, very well with these drugs. And if you look at the original clinical trials of drugs like nivolumab, all started about 6, 7, 8 years ago. They were early phase trials at that level. There are around 20% of patients, roughly 18 to 20%, who are alive 5 years later, giving you the idea, and this is in lung cancer, maybe there is a possibility of long-term disease control. So that is where she is in. David, I'm going to ask you the last question. It's a tricky one. She said to me a couple of weeks ago, this is more of a philosophical question. She said, I'm so well, can't they resect my primary tumour now?
So, as I said at the start, I think the role of surgery is very clear, and that is to work with the other specialties. But it's got to essentially be to look to clear the macroscopic disease that we have. And now we accept oligometastatic disease. And essentially, if we had evidence of just the lesion itself, and nothing anywhere else. Obviously, you'd have to also take into account what harm the surgery might do to her. She's had all these lovely treatments of yours, and she's tired. If she was very fit and we had evidence of disease or possible recurrent site, and there was just the one point, then I think surgery can certainly be discussed. But again, with no illusions, not using the word cure, but it may well be if we think that is the only site of disease that is going to give her further recurrence, then unusually we have done that, but it's got to be put very much into context.
Yeah, I agree absolutely, and I think again the value of an MDT and the value of having people you work well and closely with is you can have honest discussions. The moment she's not proceeding towards surgery, and who knows, maybe if I give this talk in 2 years' time, she'll still be well and still have her disease controlled. So there we go. Remember, the patient is the one directly affected by treatment decisions. I think that's a really important thing. We can look at all the data, we can have our erudite discussions, but in the end, the most important person in the room is the patient and what they want, and we must make sure that what we do fits in with that as well. So that's that. We're 5 minutes early. How's that, Jane? Quite an achievement. So I think I have coffee now. Is that right?
Questions?
Right?
Questions.
Oh, questions. You want to ask questions? Oh, yeah. There's questions. Excellent.
You're all very welcome.
I had to wait 15 minutes for coffee. Bad luck.
I just wanted to ask you, and thank you for the lovely talk in the MDT. I just wanted to ask you, the PDL expression, because obviously the nature of the letters that we're now getting as GPs is changed. So we're seeing a lot of these very complex letters with all these biological markers. But does it follow that the PDL expression in the tumors is intrinsically linked to the better differentiated tumor? Because I know that the histological nature may vary as it goes along, and you're using the biological agents in advanced disease because that's where the license lies. But is that because we're inherently selecting cancers that are less, better differentiated, hence they're expressing the proteins? And is there any, or do you need to give this as systemic therapy rather than targeted therapy for discrete lesions? And then you'd get less side effects, or it wouldn't work unless you stimulate the entire immune system?
So, Chris, does PD-L1 expression correlate with differentiation?
It depends what you mean by the term differentiation. Certainly, PD-L1, if you look at some of the other markers, it exists on its own. One of the things that I said at the beginning is that there are several different variants, and you heard what Tom was saying, that maybe 20% of these patients under current management will respond. What we are not good at doing at the moment, but which is going to be one of the next steps, is to look and see whether or not there are PDL variants in this 80% that are not responding, and to which there should be specific therapy for those individual patients. So there is evolution of the disease, there is expression of other parts of the genome that normally don't occur, and in those patients that appear not to respond to, if you like, the conventional therapy, to the standard proteins that are being expressed, then we have a scope to devise new therapies to look after groups of patients within that additional 80%.
I think the other thing to say is that PD-L1 is one rather inadequate way of trying to describe the interaction between the tumour and the immune system. It's all we've routinely got at the moment. I guess if we fast forward 5 years, I think we'll have 3 or 4 different ways of describing it. And I think that is important, because I think it's incumbent on all of us to make sure that these expensive drugs are targeted towards the people who will benefit from them, and we don't waste their time by giving these drugs to them if they're not going to benefit. So I think PD-L1 is what we've got at the moment. I suspect we'll have more coming along in due course. Do you mean targeted treatment as in immunotherapy? So all the trials I know about immunotherapy have all been systemically given. Are there any localized immunotherapy approaches? I'm not aware of any myself.
Not that I'm aware of. I mean, in the setting of metastatic disease, we would target systemically effectively.
Tom, there's questions here.
Just one important question I just wanted to ask, particularly in the previous trial, the patient, and this question to Chris, and then the lung group oncologist. The patient had ALK and ROS testing and EGFR and was wild type effectively. In terms of recent data out of clinical trials show, would you test for KRAS, STK11? My question is, would you do a more broader panel to predict potentially response to immunotherapy, particularly the KRAS, STK11 co-mutations tell us that patients don't respond to immunotherapy. So despite being PD-L1 positive, is there a role to, for some patients, do more broader, or for all patients effectively, do broader testing to avoid giving them immune therapies?
Is that a question to me?
Yes.
Okay, well, just to respond, you and I both know that we would encourage patients with cancer to have genomic testing, our 20 or 30 or 50 or whatever it is, genes, so that we can understand the genomic landscape within which we're working. When we talk about targeting, until a number of years ago, the target was whether or not we're dealing with a lung cancer or a breast cancer. Now the target is the specific protein. And it comes back to what we were saying a few minutes ago, and that is, in an individual patient, a gene may or may not be mutated, but the sequence, the protein sequence that comes off that gene may vary. It can be of an embryonal type, or it can be of a mature type, or it can be another variant. So if we're really going to treat the patient efficiently, and what I mean by that is to give them a drug which is appropriate for their genetic expression, then we need to know whether or not we're dealing with a standard variant or an abnormal variant. And if it's an abnormal variant, then you don't give the drug until you have a drug which is specific for that variant.
Thank you very much for such exciting presentation and discussion. That was really exciting. My question is that, is it already done, like a pre-immunotherapy or pre-operative, any radiotherapy or chemotherapy? And if it is done, does that make any difference in prognosis? Because when I see patients in the GI, they do quite often pre-operative radiotherapy or chemotherapy, and their prognosis seems to be much better.
Yeah.
But lungs I haven't seen.
Yeah, it's a really good question. So there is evidence of, trial evidence that if you give immunotherapy before surgery, you can downstage the patient. It's not a licensed treatment, and we don't understand yet whether that is going to improve outcomes, but it's very exciting. And what was interesting about it, Neil, we're discussing in Taxi Up, I think the pathological response rate was 45% or something in the nose. That's very exciting. There is ongoing trials looking at post-operative adjuvant immunotherapy. Quite difficult trials to recruit to because it's 2 years of treatment or 1 year of treatment, and a lot of patients after surgery don't really want another 2 years of treatment. The theory would go that immunotherapy is going to be most effective when there's least cancer there. And so in the adjuvant setting, that sounds quite interesting. But they're not licensed yet, and we probably won't have the data for a couple of years yet.
Is there any, as you mentioned in your lecture, the combination of chemotherapy and immunotherapy seems to be working even better?
Yes.
If that is, then is there any chance of having pre-immunotherapy with chemotherapy?
Yes, may well be. Maybe you'd, yeah.
Does that make any less side effects? Or that
It may do. Chemoimmunotherapy before operation may well be. In 5 years' time, we'll know. But at the moment, it's not a proven approach. It's not a standard treatment. Pleasure.
We hear these days now that there is possibility of low-dose CT scanning coming for detecting early lung cancers. How do you think it would roll out in terms of management? Because people, about immunotherapy, it's in the press, people know about it. What would happen?
I defer to Dr. Navani, who's an expert in lung cancer screening. He is now.
Thank you, Tom. A few biases may come out in this answer, but we've now got a wealth of high-quality data to suggest that low-dose CT screening works, and it saves lives, and it reduces mortality from lung cancer. In fact, it reduces death from all causes by about 7%. So it's a very powerful screening tool, and the tool that you mentioned is a low-dose CT scan that's carried out annually. One of the key issues about it, particularly in the UK, is about how we implement that and who we implement it for. And there's a huge amount of work going on at the moment, particularly in pilot studies in London, Liverpool, Manchester. A number of centres have set this up, which are looking at how we recruit people from the community into low-dose CT scanning, and who those people should be, and how we approach them. So I hope that in the next 3 or 4 years, the government are going to have a formal low-dose CT screening programme for individuals at risk in the UK, similar to what is available currently in the US. But for me, low-dose CT screening is the one thing that's going to, along with immunotherapy, transform outcomes in lung cancer. And if I can finish by just giving one example, currently, half of the patients I see in my clinic have advanced disease. So 50 to 60% have advanced disease. And despite the advances that we've seen today with immunotherapy, they will die with lung cancer. You know, our 5-year survival is still around 10 to 12% from lung cancer. With CT screening, the proportion of patients will see in my clinic after screening will go down to about 15%. So the majority will be switched to be detecting them at early stage disease so that they can have curative treatments like surgery and high-dose radiotherapy.
Yeah, I'd absolutely agree, which is...
immunotherapy?
Sorry?
Not for immunotherapy.
Well, no,
because-
I haven't said that at all. And I think once we, the survival of even early stage disease needs to be improved. And immunotherapy has to be, I would have thought, the best treatment to combine with surgery and high-dose radiotherapy to maximise 5-year survival for these people.
Can I ask
But
one more
we do have to wait for data to do that, and certainly if I could give less immunotherapy to people with stage 4 disease because Neil was diagnosing them earlier and David was treating them curatively, I'd be absolutely delighted.
Can I ask one more question, please? About the lung nodules. Found incidentally, followed up, diagnosed as cancer, lobectomy done, no nodes, nodes were clear, so no chemotherapy, no radiotherapy offered, and again, there is no role for immunotherapy at the moment because it's licensed for advanced stages. But do you think something like that might be curative?
I mean,
If offered? Or would there be trials on that?
there are ongoing trials of the role of immunotherapy after surgery. That is something that is happening in various stages. In that particular example, I'd expect that patient to do extremely well. And immunotherapy may not add a huge amount. But in other cases after surgery, particularly when there are lymph nodes involved, I suspect immunotherapy will have an important role. But as Tom says, we need to wait for that data.
And David,
Just one comment on the trials. I mean, these particularly very early cancers, probably what happens is that you develop actually personalized vaccines. So when you take the tumor and then effectively get yourself injected with your own vaccine. So personalized vaccine. There are trials ongoing, interesting data out, but again, it's the scalability, which will be, of course, difficult because it's very complex. But that's the future. Effectively, you vaccinate yourself with your own neoantigens.
David, just a small tumour, presumably less than 4 centimetres, lymph node negative, surgically resected. They've got a good chance, haven't they?
Well, they've got, yeah, exactly. They've got an excellent chance, but the key thing then is that they are surveyed and monitored for currently 5 years after that. It's a disease that can come back, and of course, if they develop one lung cancer, there's no reason why they shouldn't develop another, so they do need surveillance, don't they?
A gentleman in the blue shirt.
Lots of these patients will be very much immune compromised, and when they come home, the little problems that they present with are big dilemmas for GPs. One of the things that can commonly occur, the cardiologists have already said about vasculitis, deep vein thrombosis. Because they are fairly immobile, what are the chances and how long a PE can happen after pain in the legs, which we think is not DVT? That is one question. And if I may put another question, not related to the lung, you said immunotherapy has a role in thyroid cancers. Now, thyroid cancers have recently been published to be overdiagnosed and overtreated. With improvement in technology, and they have described indolent, non-progressive type of papillary tumors. Does it have a role? We had a debate in our local district hospital, and ENT surgeon said, what if you had a tumor which is non-progressive, would you sit on it or ask for a treatment? But if immunotherapy can work, then we can persuade patients to discuss the morbidity related to operation and just have immunotherapy.
In terms of thrombosis, anyone with a cancer diagnosis, particularly pelvic malignancies, are at increased risk of thrombosis. Anyone on chemotherapy, particularly platinum-based chemotherapy, is at an increased risk of thrombosis. And there are some other anti-cancer drugs, particularly ones which target blood vessel formation, called anti-angiogenics, which are also increased risk of thrombosis. And patients, some patients with cancer, as you know, have an elevated platelet count. They probably have an increased risk of thrombosis. So for any of my patients having anti-cancer treatment, I say to all of them they're increased risk of thrombosis. Immunotherapy itself appears to have a low increased incidence of thrombosis. I would suggest less than any of the other drugs I've mentioned. So I don't particularly see immunotherapy as a risk. If the patient is highly immobile, if they're in a bed more than half the waking hours, they're a poor performance status, they're performance status 3, they shouldn't be getting immunotherapy. Like all cancer drugs, immunotherapy should be given to patients with a good performance status who are going to benefit. We should not be giving it to immobile patients who are not well enough to have it. So there's no particular new management approach for immunotherapy. Oncology, about probably 8 years ago, there was a study looking at prophylactic anticoagulation for patients with cancer. There was an increased risk of bleeds. There was no improvement in survival. So we do not routinely anticoagulate people. For thyroid...
I just mean if there is an active colitis of any degree of severity, just like in UC and CD, they are very, very thrombophilic, and they should be thromboprophylactic.
Alex, from a cardiac point of view?
Yes, so I just think you're wise to think in the breathless patient, PE is obviously on the differential as they have got a higher risk because of their cancer. There's some data that's recently come out on the safety of using what was called novel oral anticoagulants, now direct oral anticoagulants, which I'm sure everyone's familiar with. So for the treatment of DVT and PE, there's been a large trial showing that rivaroxaban was safe to use. There wasn't a higher risk of bleeding, and that was compared to low molecular weight heparin. And of course, from a quality of life perspective, avoiding the daily injections. I'll tell you what I do in my practice, which is to give cancer patients who've got AF or DVT-PE and an indication for therapeutic anticoagulation. I give them 2 weeks of an injectable low molecular weight heparin, so that if they do bleed, you're more likely to see it in that initial phase, and providing there's no bleeding, then transition them to an oral direct anticoagulant for their quality of life and efficacy evidence.
I'm afraid for thyroid cancer, I'm not a thyroid cancer specialist. I can't comment. I don't know if anyone is, but I'm afraid I can't answer that question.
Tom, there's one more there.
It's a very good presentation.
Okay,
Thank you.
two more.
My question, I have a couple of questions, and my first question is, what is your practice in investigating, diagnosing, and managing possible pseudoprogression? So essentially, you've given some immunotherapy, a few months of treatment, you've done a CT scan, and on the scan, the tumour looks bigger. What's your personal practice? And then part of that question is also, how do you manage that in a clinic setting? What do you explain to the patient?
Yeah.
Because that can be quite hard for that patient to deal with. And then my second question is probably more to Professor Foster: what's the role of liquid biopsy? Is there any future role in that, in the sense of doing a blood test instead of taking a biopsy sample? Is there you've got any information about that? Thank you.
So, John, do you mind talking about pseudoprogression, something you and I see sometimes in the scans on our patients? How do you think it exists, and how do you stage patients?
So normally, yes. So once patients start immunotherapy, when you do that first scan, we do come across patients where the disease seems larger than it was on that initial study. I think it's always really important to look at the dates of your scans to make sure that the one it's being compared to is contemporary in the sequence of their treatment. I think it then depends on the patient sitting in front of you. If they demonstrate obvious symptomatic progression, then I wouldn't feel normally comfortable to sort of look at the scan and ignore their symptoms and carry on with immunotherapy, because there's every possibility you may lose the window of opportunity to switch to another treatment. And therefore, the patient who's sitting there with you who feels well, symptomatically better, but the scan suggests that things have got a little bit bigger, I would often give them the benefit of the doubt and continue with therapy until that next scan is due to be done.
And there's quite a few ongoing clinical trials are also using concept of treatment beyond progression, which is there's radiological, minor radiological changes suggesting progression, but the patient is deriving clinical benefit. The trial suggests you continue with treatment. And it'd be interesting to see how that shakes out. Chris, Toby, liquid biopsies, they're very exciting. Everyone's talking about them. What's the deal with PD-L1?
Well, it's not just PD-L1, but it's the principle, and that is that you have circulating tumour cells circulating DNA from tumour cells, and there is great appeal in the sense that one can diagnose the fact that a patient has a malignancy. Maybe even you can specify I mean, if you look at the DNA and you can find mutations of a particular pattern, you can suggest that a malignancy is arising in a certain tissue. There is no doubt that this is a very potent way of moving forwards and also of monitoring a patient, the sort of patients that we've now been hearing about, who have been treated and apparently are becoming free from their malignancy. How are you going to monitor this? And it's over and above radiology that needs to have a critical mass of tumor really to be able to visualize it. So the answer is that there is a lot of potential in developing this type of approach. Coming back to the gentleman in blue before, it overlaps with his question, and that is, cancer is not binary in the sense that you don't wake up one morning and the light switch has gone on and you've got cancer and whatever. And as a diagnostic pathologist, we're faced more and more with working in the gray zone of, is a particular appearance a benign, hyperplastic, responsive appearance, or is it an early precursor of a more sinister disease? And the same would be true with your liquid biopsies. If there's circulating DNA which is abnormal, does it actually mean that there is an established cancer, or is it a change that may regress, or would it progress? So I think in all of these areas there's exciting developments.
Yeah, just agree. So just to Chris' comments, I think three relevant areas. So the non-biopsiable patients, so particularly lung cancer where you can't get a biopsy. We've just done a study with gene panel test on 50 patients. We found, so these were patients with lung cancer where we couldn't biopsy patients. We did a circulating DNA testing on a 70 gene panel and found 7 patients who had relevant mutations, EGFR mutation and the like. So those patients who then were on standard of care chemotherapy could be switched to the more better tolerated targeted drugs. So definitely in this setting where we can't get a biopsy, to definitely do a circulating DNA test. Unfortunately, they are not reimbursed right now. However, the test, some of them are FDA approved. So again, we're getting more and more out of the gray zone into a standard of care practice. The other thing in my field, GI cancers, we see very commonly large disconcordance between original tumor and metastases, and a higher concordance between circulating DNA and the metastases, particularly in gastric cancer, gastroesophageal cancer. So again, I have changed my practice in this way that I'm using circulating DNA. There's now enough evidence and strong evidence there. So I think an increasing field, the unknown primaries, carcinoma of unknown primary as well, where we have just finished a study where we could identify patients benefiting of direct targeted drugs where tumors were more difficult to biopsy as well. Okay. And then, of course, finally, one thing, disease monitoring. This is, I think, where you're asking for, we get increasingly requests from patients to say, hey, I had cancer out, surgeon has taken it out, what are we doing? Do I have 3 monthly CT scans? Do I have circulating DNA? In GI cancers, particularly in stage 2 colorectal cancers, we know that circulating DNA can, if you do it in the right sequence, up to 5 months ahead of CT scan show you disease relapse. And that's a very important field to watch. Right now, it's not standard of care. However, some patients come with these tests and say, hey, this is my follow-up scan. Right now, it is rather confusing, can confuse patients, because it's not unusual to see artifacts, so DNA or genes being positive, and they're not really, they're the artifacts on these tests. So, it's too early to use it for disease monitoring.